Hi everyone, and in this video, I'll be discussing a topic called pharmacotherapy of mania and bipolar disorder. Now, when you think of mania, a psychiatric illness, mania is nothing but the person mood is elevated, so is hyperactive. So this is a normal level. Let us assume that is a normal level. So maniac patient are hyperactive. Now, the patient with depression, they are depressed and they have lost interest in pleasurable activities and they have low mood. So, mania is a condition where the mood is hyperactive, hyper excited. Now, what is bipolar disorder? Bipolar disorder is a condition where the patient for months he will be in mania, some months he will be in depression. So, it will come in cycles mania, depression, like that. So, that is called as bipolar disorder, and mania is another condition where the person is hyperactive. Now, what are the drugs we use in the management of mania as well as bipolar disorder? Let us understand that. Mania and bipolar disorder, the drugs what we use, the name is, main drug is called lithium. The drug is called lithium. Apart from that, we use an anti-epileptic drug, and that is called valproate. One more drug what we use is a drug by the name carbamazepine. This is used. Along with that, we use antipsychotic drugs. So we use antipsychotics. So these are the drugs which can be used for management of both mania as well as bipolar disorder. Apart from this, do we have any other drug? Yes, the name is called lamotrigine. The name is lamotrigine and that is used for bipolar disorder only. Now that is not approved for mania, it is only for bipolar disorder only. So once I understand this, you need to understand the main drug we need to study here is lithium, because we have studied valproate in detail in anti-epileptics, carbamazepine, lamotrigine, and we also studied antipsychotics in a separate video. So what is important is lithium. Remember, lithium is a beautiful drug for mania and bipolar disorder and also a beautiful drug for examiner. So most questions come from lithium. Now, can we give lithium like that? No, because lithium is like sodium. Suppose a person has to take sodium, can he take say, Na plus like that? No, he has to take it as a salt. So, lithium is available as lithium carbonate, like a salt, a lithium carbonate, like sodium chloride. This is lithium carbonate. First of all, let us understand certain pharmacokinetics important of lithium. And lithium has narrow therapeutic index. Now, can you correlate with general pharma? A drug have narrow therapeutic index means what? Meaning is it is less safe. And if it is narrow therapeutic index, we can do something called therapeutic drug monitoring. I'll discuss that later. What is therapeutic drug monitoring? Third important aspect we need to understand the half-life of the drug. The half-life of the drug is 24 hours. So half-life is 24 hours. That means approximately 1 day. Now the next important aspect is how many days are required to achieve steady state. Suppose I start a lithium, how many days are required to achieve steady state? You correlate general pharma here. To achieve steady state clinically, you require 4 to 5 half-lives. So that means you require 4 to 5 days to achieve clinical steady state. Now what about the ADME? Absorption, if I give the drug, it is 100% absorbed. The drug has 100% absorption. And does it undergo metabolism? No. The drug will not undergo metabolism. No metabolism. That means it will come out from the body as lithium itself. Will it bind to plasma protein? No plasma protein binding. No plasma protein binding. Then where it is excreted? Let me take a slide and explain to you. Excretion of lithium is more than 95%. is mainly by kidneys, that is urine. 95% is by urine. Then approximately 4% is eliminated by sweating, that is sweat glands. Sweat. Because you remember, lithium and sodium are like brothers. Wherever sodium goes, lithium also goes. So sodium is eliminated in sweat also. Now less than 1% of this lithium is excreted in tears, saliva, as well as breast milk. So if you see the breast milk, the levels are very, very low, less than 1%. Even a breastfeeding mother is on lithium and a baby breast is being breastfed. So will that be affected? Not much, because the levels of lithium which reaches the infant is very, very low. So no need to worry. So excretion part we understood. It is excreted 95% in kidney, that is via urine, and others are also there. Now once I understand this, I told you the drug has narrow therapeutic index, so we need to do something called therapeutic drug monitoring. Now very, very important. Now when we have to do therapeutic drug monitoring, will I do today only? I gave the drug, should I do it today only? No. Now when you start a drug, you should wait for 4 to 5 days. Why I should wait for minimum 4 to 5 days? So that it achieves steady state. Once it achieves steady state, for example, patient took the tablet 9 a.m. in the morning. He has taken the tablet of lithium. Should I do at 10 a.m.? No. You should do it 10 to 12 hours post dose. 10 to 12 hours post dose, you have to do lithium levels. So you have to draw the blood and then check how much is the lithium level. So patient has taken at 9 a.m. 10 to 12 hours after that only you have to draw the blood and see what is the level of lithium. Now once I know it, what should be the normal lithium level? Because we are doing TDM, we should know the normal level, and most of your exam will be asking this question. So I am telling you from the reference of Goodman and Gilman. As per Goodman and Gilman, what should be the normal level? It is around 0.6 to 1.0 milliequivalent per liter. So this is for when you are using the drug for prophylaxis of mania, as well as when you use it for prophylaxis of bipolar disorder. You have to maintain that much. Now, if you increase the level, for example, 1.0 to 1.5, the units remain the same, milliequivalent per liter, then this is utilized for acute mania. During acute mania, you can maintain the level up to this. Then, if the level goes above 1.5, so you have to suspect toxicity. There is a chance of toxicity more than 1.5. So should we admit a patient for that? If the patient has no symptom of lithium toxicity, no need to admit. Now if the levels go above 2 milliequivalents per liter, then you have to admit the patient. Hospital admission is required. Hospital admission is required. Okay, sir. Sir, if lithium toxicity occurs, how do I remove lithium from the body? Is there any method? Is lithium toxicity having any antidote? No. If there is no antidote, then what should I do? Remove it by dialysis. So, if the levels are more than 3 milliequivalents per liter, then we can do dialysis and remove the excess of lithium from the body. So, this is what the normal lithium levels and overdose levels. But in certain patients, we use lithium for treating depression as an additional drug. So we call it as adjuvant drug. For that, we can maintain the level between 0.4 to 0.8 milliequivalent per liter, and that is for depression. When you use lithium as adjunctive drug for depression, then the level is 0.4 to 0.8 milliequivalent per liter. This is the level. So once I understand the pharmacokinetics, very important, let us understand how lithium works. What is the mechanism of action? What is the mechanism of action? To understand that, let us understand certain basics. Now, mania as well as bipolar disorder. Now, please understand the mechanisms are a theories. They are trying to understand every day. Whatever we are proposing is a theory what they have understood till now. Now, the theory is when you activate GQ in the brain, GQ couple receptor, these are going to cause mania. So, when you activate GQ, they are going to cause mania. The second important theory is when there is decrease in brain derived neurotropic factor, and that is responsible for causing depression. So, when you decrease BDNF in the brain, it will cause depression. Now, you pause the video and think and tell me, if I want to treat depression, what should I do? If I want to treat mania, what should I do? To treat depression, you have to increase the activity of BDNF, and to manage mania, you have to stop the activation of GQ. So, these are the two things. Understood? Now, what is the role of BDNF? Brain derived neurotropic factor. It has two important aspects. It causes neuroadaptation, and it also increases neuroplasticity. Now, what do you mean by neuroplasticity? So, here the brain cells make more synapses. So, if you are making more and more synapses in the brain, the depression will not occur. That is a theory proposed for that. So, that is the advantage of brain derived neurotropic factor. We'll discuss that in depression also. So, with that background in our mind, let us understand what does lithium do. So, let us understand lithium. Let me write lithium for you. So, when I talk of lithium, lithium has two important mechanisms. It has shown to decrease GSK 3 beta. So, GSK stands for glycogen synthase kinase 3 beta in the brain. So, when you decrease that, there is increase in activity of beta catenin. So, these are increased in the brain. And when beta catenin increases, it has shown to increase BDNF. Now, you know that when the brain BDNF increases, what you can treat? The treatment of depression can be taken care of. So, lithium can treat depression. Now, moving on to the next aspect, the GQ. So, whenever the brain is under mania, the GQ is hyperactive. You know from general pharma, GQ will be split into diacylglycerol and IP3. You get IP3 and DAG. And this IP3 is split into IP2. And then IP2 is again split into IP1. From IP1, we get inositol. From inositol, we get phosphatidyl inositol monophosphate, and from that we get phosphatidyl inositol biphosphate. And again, when you activate the GQ, PIP2 is split into DAG and IP3. We get the same thing. So the enzyme it will convert PIP2 into DAG and IP3 is called phospholipase C. So they can also ask you in the exam what is the role of phospholipase C, right? So it will split phosphatidyl inositol phosphate 2 into IP3 as well as DAG. So let me explain again. In mania, the GQ is hyperactive, and that will activate phospholipase C, which will split phosphatidyl inositol biphosphate into IP3 and DAG. And this IP3 and DAG are responsible for causing mania. So you see mania effects. Now IP3 will be converted to IP2, IP1, inositol, and PAP and PAP2. Now what is the role of lithium? So the role of lithium is to inhibit the conversion from here to here. So it inhibits the conversion of IP2 to IP1, IP1 to inositol. So what happens if you are not allowing that cycle to repeat? The GQ activation decreases. So penultimately there is decrease in inositol activation. So inositol will decrease, the GQ activation decreases. So guys, what happens if GQ activation decreases? What happens to mania? So the mania decreases. So you can use it in the treatment of mania. Now that's the reason it can take care of depression, it can take care of mania. So lithium is also called as mood stabilizer. So it is called as mood stabilizer. You all have in your home the electronic gadgets like TV, refrigerator, AC. For that we have a stabilizer. What does stabilizer do? When the voltage comes too much, it will stop that high voltage and protects the electronic device. So it will make the voltage normal. Again, if the low voltage is too low, the stabilizer will stabilize the voltage and gives the proper voltage to the TV or electronic devices, and it will protect them. So if the patient is having mania, it will bring the mania to normal. If the patient is having depression, it will make the depression to normal. So that's the reason it is called as mood stabilizer. Lithium is called as mood stabilizer because it will stabilize. It will not do like this. Suppose the mania patient is in mania, it will not go make the patient depressed. So it will stabilize. That's why it is called mood stabilizer, and we can use it in the management of mania. We can use it in bipolar disorder as well as in depression also. That is a specialty of lithium. So these are all proposed theories of lithium, what we know till now. Now, once I know the mechanism of action, let us understand the uses. So, what are the uses of lithium? Where do you use lithium? So, obviously, it is used in mania and bipolar disorder. So, it is used in mania and bipolar disorder prophylaxis. And for both, the drug of choice is lithium. So, for mania and bipolar disorder prophylaxis, the drug of choice is lithium. Can we use lithium in acute mania? Yes, you can use it. But the drug is not the drug of choice for acute mania because the lithium starts working after 2 to 3 weeks. After 2 to 3 weeks. So when you start lithium, it will not work immediately. Suppose patient comes with mania, if I give lithium only, you have to wait for 2 to 3 weeks. You have to tie the person in the bed and wait. Not possible. So I'll tell you what are the drugs used for acute mania. So when the patient is in acute mania, we have to make the patient sedated. We use benzodiazepines plus antipsychotics. So we give antipsychotics. Along with that, we add lithium. So this is how we manage a case of acute mania. So you please understand, even we use it in acute mania, lithium is not a drug of choice because it takes time, 2 to 3 weeks. And then we have to calm down the patient. We add benzodiazepines like lorazepam, diazepam with antipsychotics and add lithium. So once the acute mania phase is gone, then you can give lithium. Until that, 2 to 3 weeks later, lithium effect would have started. Prophylaxis, you can give drug of choice is lithium. Now, lithium can also be used in if the patient has only depression, that is unipolar depression. So it can be used for unipolar depression. And one more important use of lithium, it can be used in leukopenia. It is used in leukopenia. One more headache, which is important, is it is used in a headache called hypnic headache. So these are the different understanding of uses of lithium: mania, bipolar disorder, acute mania, unipolar depression, leukopenia. I'll tell you why it is used in leukopenia, and also hypnic headache. One of the advantage of lithium is a drug which has shown to produce anti-suicidal effect. So it is one of the kind of drug which has shown to produce anti-suicidal effect. Now, many a times patients with depression they can commit suicide, and we want to stop that. And drug has this property. Can you tell me one more antipsychotic which has anti-suicidal effect? Let us do the lateral learning. Yes, it is called clozapine. So these are the two drugs which are shown to produce anti-suicidal effect. Why it is important? Because a patient with depression they are known to commit suicides, and these drugs are very good for them. They will prevent a suicidal risk. So until now, I understood what are drugs for mania and bipolar disorder. I understood pharmacokinetics of lithium. Then I understood mechanism of action, then uses. Now, once we understand all these things, what is the adverse effect of lithium? You may be wondering why lithium is being told so extensively, because lithium, I told you, every year the exam questions appear in this. What are the adverse effect of lithium? So what are the adverse effect of lithium? You can remember by the mnemonic, just write it here. All fat, sick hen fell. So all the fat, sick hen fell down. So all stands for the drug produces alopecia. The drug produces alopecia and it can produce acne. Second, fat, the drug will produce weight gain. Patients will have weight gain. And yes, for the drug can produce seizures and it can produce sinus node dysfunction. So sinus node dysfunction can lead to AV block. So patient may have AV block, and because of that, the AV blocking agent should be avoided with lithium because of sinus node dysfunction. Now H stands for a drug produces hypothyroidism. Hypothyroidism. The drug produces hypothyroidism. That is the most common problem. They will ask you, will it produce hyperthyroidism also? Yes, it can produce hyperthyroidism also. But the hyperthyroidism is rare, because when I take classes, students keep on asking, sir, some books give it is causing hyperthyroidism. Yes, it will cause, but rare. But major adverse effect, you need to remember, lithium causes hypothyroidism. Very much important. Now, the next important aspect, I will write H for you. What happens if I give lithium high dose? That means lithium toxicity. Whenever lithium is given at high dose, lithium will cause coarse tremors. Patients will have coarse tremors. Patients will have ataxia, tinnitus, diarrhea, as well as seizures. So remember, if in the exam they are given coarse tremors, tinnitus, seizures, so that means you are suspecting lithium toxicity. Remember coarse tremors in the question. So that is seen with the toxic concentration of lithium. Now E for the drug is known to produce Epstein's anomaly. The drug will produce Epstein's anomaly. The meaning is, when we give lithium to a pregnant woman, lithium is teratogenic. So what is Epstein's anomaly? Epstein's anomaly is a cardiovascular defect and there will be tricuspid atresia. Now other teratogenic effect of lithium are it produces hypotonia. So the baby will have floppy. So it is called floppy baby. And second important, it causes hypothyroidism, so there is a chance of fetal goiter, and the baby will have the cardiovascular defect, that is Epstein's anomaly, floppy baby, and fetal goiter. So these are the most important thing, teratogenic effect, you have to keep in your mind. Okay, then moving on to the other aspect, what is N for? So N stands for the drug produces nephrogenic diabetes insipidus. The drug produces nephrogenic diabetes insipidus. Now, why it causes nephrogenic diabetes insipidus, I will explain in the next slide. Suppose this is the lumen of the kidney and this is the cell. Now, when we check the collecting duct, we know that in the collecting duct we have a channel called ENaC. So ENaC is a channel which allows sodium to enter inside. Same place the lithium also enters. So the lithium enters inside So once it enters inside, it inhibits the activity of GSK3 beta. So when it inhibits the activity of GSK3 beta, it decreases the activity of ADH, that is antidiuretic hormone. So there is no antidiuretic hormone, no aquaporins. So if there is no aquaporin, so what happens? The action of ADH is not there and the water is lost. So when the water is lost, we call it as polyuria and the diabetes insipidus. So this is called lithium induced diabetes insipidus. So entry of lithium is the problem. So what should I do? You don't allow lithium to enter, then there is no problem of diabetes insipidus. Then who will block that ENaC channel? The drug which blocks that ENaC channel is called amyloride. So amyloride is the drug of choice for lithium induced diabetes insipidus. So that is the drug of choice. So once I understand this concept, let us come back. Then F4, it is known to produce fine tremors. So lithium causes fine tremors and this is common. It's the most common adverse effect what we see with lithium. E4, the drug produces ECG changes. So ECG changes, should we worry for that? The ECG changes what we see is T wave flattening and it is not to be worried. So it's a normal finding, not to worry. L for it causes leukocytosis. That means it increases the WBC count. That's the reason I wrote already. It is used in the management of leukopenia. Now L stands for loose stools, that is diarrhea. So the drug can cause loose stools. So you can remember the adverse effect of lithium with this. Now you may wonder, sir, should we remember so many adverse effects of lithium? Yes, they have asked all these things. That's why we have made a mnemonic. All fat, sick, hen, fell. So all for alopecia, acne, fat, weight gain, sick, seizures, sinus node dysfunction, H for hypothyroidism. They can also ask you a clinical based question. Suppose patient is on lithium and they develop hypothyroidism. What is your next step? Should we stop lithium or something else? Don't stop lithium because patient has treated for mania and BPD. So if there is hypothyroidism, we continue lithium. Along with that, we add levothyroxine and treat the patient. Sir, will it cause hypothyroidism? Hyperthyroidism, mainly hypothyroidism, very rarely hyperthyroidism. So remember, it's mainly hypothyroidism. High dose. So if you see in the question, coarse tremor, tinnitus, diarrhea, so it points towards lithium toxicity. Then you have to write the treatment for that. Then Epstein's anomaly, the drug is teratogenic. It produces the CVS defect, floppy baby as well as fetal goiter. Fine tremor is most common. Then it produces nephrogenic diabetes insipidus. EC changes are T wave flattening. It causes leukocytosis and loose stools. So that is about the adverse effect of lithium. Moving on to the drug interactions. So what drug we should not use it with lithium? Most commonly in your exams, they will ask you this question: lithium plus thiazide diuretics. Now, can we combine them together? What is the problem? So, lithium plus thiazide diuretic, can we combine them together is a question. Now, let me write a nephron. This is the nephron, the proximal convertibule. Then we have the descending, then ascending loop of Henle, and then the early part of DCT and the collecting duct. So this is the part of nephron. Now when I use a thiazide diuretics, so it will be a recap for you. Thiazide diuretics, they act in early part of DCT. And what do they inhibit? Anybody? They inhibit sodium chloride symport. So they inhibit the sodium chloride symport. So sodium is lost in the urine. So when the sodium is lost, so that will cause a hyponatremia condition. Now what happens if sodium is less in the body? The nephron tries to reabsorb sodium back. So sodium is reabsorbed from the PCT more. Now I told you body will handle sodium and lithium in same way. So sodium is reabsorbed, lithium is also reabsorbed. Now we know that lithium has narrow therapeutic index, and if it is reabsorbed back, the lithium level increases. So that will lead to increase in lithium levels. So obviously when the lithium levels are high, so it will lead to lithium toxicity. Lithium toxicity. So the message is lithium and thiazide should not be combined, and they can cause lithium toxicity, and that is a mechanism. Now, one thing you all observed, hyponatremia can trigger lithium toxicity, and I told you the mechanism. Wherever you see hyponatremia, the kidney tries to preserve sodium, along with that, it will also reabsorb lithium again. Sir, what about other diuretics? Will they also increase lithium toxicity? No. So it is mainly seen with thiazide diuretic. Very minimal with loop diuretics. Then moving on to the important aspect, when we understood that what diseases trigger lithium toxicity. For example, patient is doing too much of fasting, or patient is too much dehydrated, or patient is having severe diarrhea and dehydrated. These are the conditions where patient will have hyponatremia. Hyponatremia, I told you, can increase lithium levels, and that's the reason they can cause lithium toxicity. So they can give a case: patient was in fasting for so many days, and he came with coarse tremors, diarrhea, okay, and tinnitus. What is it? Lithium toxicity. Now same thing happens in one of application, heavy sweating. So when there is heavy sweating, there is loss of sodium and water normally. So somebody is having heavy sweating and he drinks only water. Water is given to the person without adding electrolyte. What happens when he drinks water only? The water will dilute the sodium, so that will cause hyponatremia. And that hyponatremia can trigger lithium toxicity. So what is the take home message? If there is heavy sweating, along with water, you have to add electrolytes, particularly sodium chloride. So that is the message, you got it. So hyponatremia can trigger lithium toxicity. Once we have understood the drug interaction, let us understand certain example of cases. Let me tell you some case. Case 1. Suppose a patient has bipolar disorder. I told you bipolar disorder, patient may have mania or depression. So he came to a psychiatrist, and when he came, patient had a depression phase. So what the psychiatrist did is he gave for the person only antidepressants. He was given antidepressants only. Now, can you tell me, if a patient has depression, he is a bipolar disorder patient, and you give antidepressant only, what will happen? Think and tell me. Patient will manifest mania because they are at both poles. When you suppress depression, mania will manifest. Antidepressant will not take care of mania, and they are not mood stabilizer. They can only treat depression. So, if a patient with bipolar disorder has only depression, when he presents to the hospital, you should not give antidepressant alone. Mania will manifest. Let me tell you case 2. Same patient, bipolar disorder, he is having depression. Now he is in depression pole. Now he was given lithium. Now you think and tell me, guys, if I give lithium alone, will they have mania? No. The reason is lithium can act as mood stabilizer. Suppose patient is having depression, this is the normal level. The depression will get corrected. That's the advantage. And even if the mania shoots up, it's a mood stabilizer. It will bring down mania also. So it's a mood stabilizer, and you can use lithium alone for this. No problem. So it can take care of both the poles. That's why lithium is called mood stabilizer. Now another important aspect I want to tell you, again we'll discuss what are the drugs for mania and bipolar disorder. What are the drugs we use? Mania and bipolar disorder, the drugs we use are lithium, and we know that lithium is the drug of choice for mania and bipolar disorder prophylaxis. Second, other options what we have is valproate. Now valproate is the drug of choice for rapid cyclers. Rapid cyclers. So don't think it as cycling. Rapid cyclers are nothing but if they have mania depression, that is one cycle. So if that cycle repeats more than four in a year, if that is more than four, they are called rapid cyclers. And the best drug for that is valproate. Then we also use carbamazepine and antipsychotic drugs in the management of these conditions. Yes, fine. Now there is one more drug, lamotrigine, which is an anti-epileptic drug. It is approved for bipolar disorder only. Lamotrigine is approved for bipolar disorder only, and it is not used in the management of mania. Now the next important aspect, what if patient comes with acute mania? Is acutely maniac, hyperactive? First of all, when he is so much hyperactive, you have to calm down him. So what we do is we add benzodiazepine. Along with that, we give antipsychotic medicines. So we add along with that lithium. Now, why lithium is not the drug of choice for acute mania? I told you lithium has slow onset of action. It takes around 2 to 3 weeks to start working. So that's the reason we have to give benzodiazepine, antipsychotic plus lithium. The same question may appear. Suppose mania and bipolar disorder in a pregnant woman. She is pregnant and she has mania and bipolar disorder. Then what is the next step? Now remember, whatever drugs we are using, for example, valproate, it is the most teratogenic drug, and next one is carbamazepine, and next one is lithium. So whatever option we have, all have teratogenic potential. The highest with valproate, intermediate, and least, but all are teratogenic. So the what is remaining is antipsychotics, particularly the best one for a pregnant one is atypical antipsychotics can be used. They can be used. So in one of the exam, the examiner tricked the student. They asked, a pregnant woman has come with bipolar disorder. Which one will you avoid? Valproate, carbamazepine, lithium, atypical antipsychotic. So the question is not drug of choice. The question is which one will avoid. The answer is valproate because of more teratogenic potential. The next important aspect is lamotrigine safe in pregnancy? Yes, lamotrigine can be used. It's safe in pregnancy. And we have better drug than that, that is atypical antipsychotics. You can use them for both mania and bipolar disorder. So this is about the discussion about the pharmacotherapy of mania and bipolar disorder. We started with what are the treatment aspect, then we understood lithium, what are the pharmacokinetics, how does it work, mechanism of action, that is the proposed theory, then uses, the adverse effect extensively we studied drug interactions and what triggers lithium toxicity, and the case based approach, what are the cases, how do they ask, and how do you manage acute mania, how do you manage mania and bipolar disorder in pregnancy. So that is about the aspect mania and bipolar disorder treatment. Thank you all.